Good evening. Good evening. This is Dr. Mike Slowey from Coastal Fertility Specialists with our July issue of the Coastal Quickie. What we're going to do tonight is we're going to talk about a condition called Polycystic Ovary Syndrome. We're going to be focusing primarily on the screen because, frankly, at 63, you don't really want to see me. So we'll focus on all the information that we're going to talk about tonight. So Polycystic Ovary Syndrome is a common metabolic disorder that has a profound impact on the reproductive system. It's got its name in the 1930s when Michael Stein and Irving Leventhal were operating on women who had very significant hair growth and irregular periods and heavy periods. And they found these large multicystic ovaries, which we saw actually on the previous slide. Because it was discovered by gynecologists, we lost a lot of the feel for all of the other things that go along with it. And that's what we want to emphasize tonight, although our focus will be on fertility. So PCOS is a common metabolic disorder, and it does have a big impact on reproduction. 10 to 15% of reproductive age women, and 90% of the women who have irregular cycles. Now, polycystic ovary syndrome has a complex genetic background. Studies called gene-wide association studies have demonstrated at least 16 robust genes for polycystic ovary syndrome. And the varying presentations that we see of polycystic ovary syndrome have to do with how these genes are expressed. Very, very importantly for everybody, polycystic ovary syndrome can have an impact on nearly all aspects of a woman's life after puberty. And as we talk about the genes being expressed, this is kind of everything in life. Genetics and our environmental exposures, well, it equals everything. And it has a big influence on polycystic ovary syndrome. So what would be the exposures? Well, it can actually start prenatally. When you are an embryo, what kind of things did your mother eat? Did your mother smoke? Was your mother gaining a lot of weight? All of those things can influence how genes are expressed. And then as a child after birth, what did we eat? What are our activities? What are other environmental exposures? And so on and so on. So one question to say is this polycystic ovary syndrome that has this profound influence on our lives, and it's genetic. Well, what about evolution? Why are these genes still persisting? Well, for our ancestors, polycystic ovary syndrome had some very distinct advantages. Because of the irregular cycles, these women got pregnant less often, and it increased their chance of surviving because pregnancy is not a benign condition. This year alone, 500,000 women are going to die because of pregnancy-related complications worldwide. Now, granted, most of that's not in the developed world, but as we think back to olden times, we can see how having fewer pregnancy increases your chances of surviving. I think a really important part of it is under low food conditions, the PCOS patient who tends to be heavy loses weight. Well, guess what happens when they lose weight? Their cycles resume, and then they can actually get pregnant. So basically, nested within our population are 10% of our women who can get pregnant under low food conditions. And then finally, because of the increased androgens, the male hormones, what does that do? Well, it can increase muscle mass, and you can actually have a better immune response, which also increases survivals. So for our ancestors, these were actually advantages of PCOS. But now things change. 10,000 years ago, we changed from a hunter-gatherer lifestyle and merged into farmers. And then 300 years ago, we started the Industrial Revolution. So a big change in the activity from farming to being in one place. And then now we have our digital revolution where we're all sitting on our butts most of the time. And that's just not enough time for evolutionary adaptation in terms of our ability to handle our energy supplies. And then those advantages become disadvantages. Because of the reproductive abnormalities, we have a hard time attaining pregnancy, and then pregnancy becomes more risky, which we'll talk about later. And then long term, there's going to be an increased risk for cardiovascular disease, strokes, cancers, anxiety, depression. So, how do we end up with polycystic ovary syndrome? How does it manifest itself to us? Now, this is a busy slide, and if you're on your phone, you're not going to have a chance of actually seeing this. But let's work our way through it anyways. So, it starts out with, where does our energy come from? Well, we're not plants, so it doesn't come from the sun, so it comes from food. So we eat food, and it's broken down into its components: fats, carbohydrates, proteins. And the carbohydrates are sugars. So all of that gets absorbed, and in response to the sugars being absorbed, our pancreas secretes insulin, which goes to the cells in our body and causes the cells to take up the to take up the sugars to use for energy. Diabetes is when this process doesn't work. Type 1 diabetes is when the pancreas doesn't work, and therefore we're low on insulin. So those are people that take shots of insulin to keep their sugars normal. Type 2 diabetes, pancreas works fine, but it takes more insulin to try to get the cells to work. So we have a lot of insulin around. These people take pills called insulin sensitizing agents, like the drug metformin, to help their cells respond to the insulin more appropriately and thus take up the sugars. Polycystic ovary syndrome is related to type 2 diabetes. Now, most of the PCOS patients are not diabetic, but it takes more insulin than normal to keep their sugars in the normal range, and that's where our problems start. So again, let's see if we can work our way through this graph. So we have our genetics with our chromosome and our environment, and we have a nice burger and fries right there, okay? We have insulin resistance, and now in the polycystic ovary syndrome patient, it's in the fat tissue and in the muscle tissue. Because of the insulin resistance, we have higher insulin levels available, and one of the things that does is it goes to the liver, and it causes the liver to make the growth factors IGF-1 and IGF-2. Now, normally, IGF-1 and IGF-2 control how many little follicles survive in the ovary, and normally there's 5 to 10 that survive. But because of these growth factors, we end up with more follicles surviving, so we end up with 20, 30, 40 on each ovary. That's the name, polycystic. The little follicle that contains the egg is a cyst, a fluid-filled sac. They're normal. They're supposed to be there. But now I got too many of them. And that's a problem because they're making male hormones, which again is exactly what they're supposed to be making, but now I have too many of them doing it. So what do these male hormones do? Well, we get the male hormones that are released, and they can create problems with the skin, acne, hair growth. They can create an anabolic state, a storage state, so it's easy to gain weight, hard to lose weight, which is why 3/4 or more of our PCOS patients are overweight. You can end up with altered lipid levels, LDL, cholesterol, all that stuff, and that all combines to increase cardiovascular risks. Then on top of it, the male hormones, the androgens, are converted to a female hormone, estrogen, estrone, by the fat tissue. Then the estrogen will go to the uterus, and then it will go to the brain. At the level of the uterus, it causes the lining to grow and grow and grow, and then you outgrow your blood supply. So you get this infrequent but heavy shedding. And while that's really annoying, the real risk is over many years without appropriate protection, like birth control pills, PCOS patients have a decent shot at growing a cancer of the lining of the uterus. So the message there is for the patient with PCOS to be on birth control pills when they're not trying to get pregnant. Then those estrogens are also feeding back to the brain to alter how the pituitary gland works. Normally, we release more of the hormone FSH, follicle stimulating hormone, than the hormone LH. But in PCOS, we tend to release more LH, which causes the ovaries to secrete more male hormones. So the whole problem is starting off at this level with the insulin resistance in the muscle and the fat tissue, but then we end up with this big circuit promoting male hormone production. Now, I kind of kiddingly call that the unified theory of polycystic ovary syndrome. That's everybody having everything. But that's really only about a third of the women with polycystic ovary syndrome. All right. Now, that's where PCOS comes from. Well, how do we make the diagnosis of it? That's a long, complicated story. But basically, the most accepted criteria come from a 2012 workshop at the National Institutes of Health, and they came up with this. Number one, there are three major criteria, and you need two of the three of them. They are menstrual cycle irregularity, some sign of male hormone excess, either on blood work or on exam, and then we have a high number of little follicles on ultrasound. And again, you need two of the three of that. Plus, other causes of like irregular cycles, pituitary problems, uterine problems, other metabolic problems have been excluded. So when we evaluate, that's exactly what we do. I like to simplify it: brain, ovaries, uterus, metabolic environment. So when we're looking at the brain, we're saying, are the parts of your brain that control your cycle, the hypothalamus and pituitary, are they working properly? So you check the hormones, FSH, follicle stimulating hormone, and LH, luteinizing hormone. When I say ovaries, actually what I'm looking at is reproductive aging, the process of having fewer normal eggs. And that's important because as somebody's ovaries get down the aging timeline, the cycles can become irregular. So we definitely don't want to miss that. We check the FSH and LH again, an ultrasound will help, and then the hormone, anti-Müllerian hormone, will help. Yes, the uterus can be a cause of irregular cycles, but quite honestly, the uterus tends to be an innocent bystander, tends to respond to the hormonal environment that we send it. And if the cycles are off, it's usually because we're sending the wrong signals. And then we have the metabolic environment. We look at thyroid function, a hormone called prolactin. We look at the adrenal gland because adrenal problems can cause irregular cycles. And then there's polycystic ovary syndrome. And of course, when we're trying to get pregnant, we do our basic infertility evaluation, look at a semen analysis, do an X-ray test to look at the uterus and the fallopian tubes, the hysterosalpingogram, and then obviously the PCOS evaluation is the uterine evaluation. And then, of course, we're very interested in the overall health because we don't define success here at Coastal Fertility simply as a pregnancy test being positive and we pat you on the butt going out the door to the OB. We define success as a healthy mom and a healthy baby when everything is done. And that has to do with how we look at things up front. We'll get into that in a bit. All right.
Someone has a question.
Yes, ma'am.
Okay. Can you have regular periods and ovaries without cysts and still have PCOS?
No. You have to have, if we think about it, we can have 4 different phenotypes. Let me see if I can go back. So we can have 4 different phenotypes. We can have the person who has everything, irregular cycles, androgen excess follicles. That's the classic PCO. We can have irregular cycles and have androgen excess, like excess hair growth. We can have androgen excess and we can have a high number of follicles, but we can still have regular cycles and do that. Or we can have excess number of follicles and menstrual cycle irregularity with normal androgen levels, which is actually probably the second most common thing that we see. But if you have regular cycles and you have normal follicle count, we only maybe have one of the 3 forms. Okay. All right. So what do we do for folks when we're confident that we have PCOS? And this is going to assume that we have a normal pathway. The HSG is normal and we have a normal semen analysis. So these are my treatment options: lifestyle changes, insulin sensitizing agents, diabetes drugs, oral ovulation induction agents, pills that cause you to ovulate, injectable ovulation induction agents. There's surgery that can be done, and in vitro fertilization. So lifestyle changes for the overweight and obese PCO, I think, are a very, very important part of it. Number one, losing weight can increase the chances of ovulation and increase the chances for pregnancy. Many of our overweight PCOs, if they lose 15% of their body weight, may start to ovulate on their own and may not even need our help. It clearly reduces the pregnancy complications because as we gain weight, all the risks of pregnancy increase. Certainly, losing weight will improve lifelong health and probably should be a part of everybody's therapy, at least to some degree, depending on what our problems are. Now, how we go about it, certainly we look for the obese patient. We have to talk about obesity because it is very complex. We talk about reducing calories, all right? There's all this nonsense about different carbs and fats and all this kind of stuff. It's all nonsense. It's all about calories, all right? Now, that part of it's simple. The other part's hard because we're designed to store. We are still hunter-gatherers. We are really, really good at storage. So as we gain weight, we become more adept at storage, and we don't like to lose that weight because we're very efficient. And then PCOS is a pro-storage state on top of it. So it is really harder for the PCOS patient to lose weight, but we got to try for safety reasons, primarily in pregnancy, okay? For example, in our practice, we don't initiate treatments to try to get somebody pregnant until a BMI is under 40. And the reason for that is because at the body mass index of 40, the pregnancy risks skyrocket. And if you're a BMI of 45, 50, the pregnancy complications can be very, very dramatic and life-threatening. So we like to get people to a little bit safer place before we move on. Because again, healthy mom, healthy baby. There's no diet that's better than any other one. We want people to do things that they're comfortable with. Whether it's a zone diet, beach body diet, South Beach diet, yeah, they all have their carb shtick. You can ignore that. But they're all balanced diets, healthy foods, lower calories. Exercise is important. Diet's more important, though. 150 minutes a week, so 2.5 hours a week, preferably 5 times a week. So 30 minutes 5 times a week. Frequency is more important. I'd rather have somebody go 15 minutes 5 times a week than 2.5 hours 1 day a week, okay? And then if things are difficult, we got to get with dietitians, psychologists, maybe a trainer. These are people that can help us focus on working these things. And generally, we want to have achievable goals. I don't tell anybody to lose 50 pounds next week. For crying out loud, that'd be really, really unhealthy. But we try to have reasonable goals with this. And lifestyle changes can have a dramatic impact. This is a nice study that was published 12 years ago that looked at 334 overweight. So these are not real big people, but look at this. The highest pregnancy rate actually was in the lifestyle group versus diabetes drugs or simple ovulation induction. This particular study was not significant. So if this were expanded, it probably would be. But at the same time, you go, you know what? This works just as good as taking drugs. All right, speaking of drugs, what about medicines that we use to cause women to ovulate? So I've got diabetes drugs, pills that cause you to ovulate, and injectable medicines that cause you to ovulate, okay? So metformin is the drug of choice. It is an insulin sensitizing agent. Fun fact about it, it was actually discovered in 1922 from the French lilac. They started to use it for PCOS in Europe in 1994, and in 1995 it was approved by the FDA for type 2 diabetes, and we started using it for PCOS shortly thereafter. Now, what it does, it blocks glucose uptake. It stops the liver from making glucose and decreases intestinal glucose absorption. One of the two reasons we really like it, it does not cause low blood sugar, and it's category B in safety, so we think it's pretty safe. The downside to it is there's a lot of gastrointestinal side effects, nausea, bloating, diarrhea. You're welcome. So we try not to use it unless we really, really feel like we need it. In terms of how it helps, yes, it does increase the chances of ovulation compared to taking nothing, but it's really only about a quarter of the women that start to ovulate. That's why we, in really contemporary times, we don't use it by itself. Does it help other agents? I think in some people it probably does, and in other people it probably reduces the risk of pregnancy. Without a doubt, it has been shown to reduce the risk of diabetes in the people who are pre-diabetic, so very, very insulin resistant, by a third, which I think is also a very important thing. But again, we don't use it in everybody. We do testing to look at, to say what can be helpful. Now, what are some of the pills that cause you to ovulate? There are three: Clomid, clomiphene citrate, tamoxifen, and letrozole. Now, very interestingly, all three were developed as breast cancer treatments. Clomid in the 1950s, tamoxifen in the late 60s, and letrozole in the late 80s. They work through slightly different mechanisms, but the common mechanism, they cause the brain to release the hormone FSH, which in turn gets the follicles in the ovary to start growing. And they're all similarly effective. 60 to 70% will ovulate, release an egg, and about half of those will conceive if you give them enough time, 4 to 6 months. The major side effects are mood swings, with Clomid having the most. You can have hot flashes, and especially with Clomid, you can get thinning of the lining in about 10% of the people. Tamoxifen we don't use as much because we have letrozole, which you have these side effects, but they're markedly reduced. I think the pregnancy rates are really about the same, but because of fewer side effects and a lower risk of twins with letrozole, that's why we think letrozole is the drug of choice. But if somebody's using Clomid, I still think it's a good drug, and I do still use it in certain situations. All right. Then we have injectable medicines that we call gonadotropins. So when do we use those? So if you used an oral medicine and you didn't respond, or you used it and you just didn't get pregnant. There are people who don't tolerate the oral medicine, so you got to use some. And for some people, we'll consider it a first-line treatment. They're about 50% more effective than the oral agents, but the oral agents are so easy to use. And these medicines, because some women with PCOS, they'll respond, but their ovaries will just take right off. They'll hyper-respond. But of the people we can do safely, we'll get about 40% pregnant in about 3 to 4 months, typically. But again, this is not something a general OBGYN can do. It takes a lot of practice and expertise to be able to monitor this stuff. We use ultrasound and hormone levels, primarily estrogen. The risk of multiple pregnancy, if not monitored appropriately, can be significant. Typically, we see about 10% in our patient population. The risk of ovarian hyperstimulation syndrome, which is a condition where there are fluid shifts, electrolyte abnormality, clotting disorders, can occur with this, but with the way we monitor in contemporary times, it just simply doesn't happen with this. And we don't really even see it much more with IVF because of different medicines we're using there. All right. Surgery for PCOS was actually the very first treatment for it. Stein and Leventhal in the 1930s did what they called a wedge resection. So this is an ovary, and they're cutting out about a third of it. And their reasoning was these ovaries were making male hormones. So what would happen if I took away the source of the male hormones? They took a big chunk out of the ovaries. You know what? It worked, and it worked really well. Look how many women would ovulate, and a whole bunch would get pregnant. Very low multiple pregnancy rate. Miscarriage rate was actually pretty typical for their age. Some studies reported 50, but usually we're in the 10, 15% range. The problem is this is done with an open procedure, so you can get some pretty significant scar tissue formation. But the wedge resection was really a standard for almost 40 years. And it was a good use for when, after Clomid came on board, it really in the 60s, as a backup when that didn't work. In the 80s, when laparoscopy came about, people were trying to come up with ways to take open procedures and convert them to laparoscopic procedures. And so what they did is they said, well, what if we use a laser or an electrode to drill into the ovary and kill the tissue that's making the androgens? And sure enough, it works really well. So this is a picture of somebody who's undergone ovarian drilling. So these are little holes made actually with a YAG laser, and works just as good as the wedge resection. 70 to 90% will ovulate. A pretty fair bunch of them get pregnant. Very small multiple risk. Miscarriage risk tends to run around 20%. So anymore, because we have the medicines, of course, why do we subject somebody to surgery if we don't need to? But if I have a reason to go in on a PCOS patient for another reason, one of the things we'll talk about is, should we do ovarian drilling while we're there? And sometimes we do. Not often. I may do 1 or 2 a year to give you some perspective on that. But so it's not a first-line therapy, but if I got a reason to be in there, it can be something worthwhile. Yes, we have a question.
Yes. How long do women need to be on Clomid, tamoxifen, and letrozole?
We think the magic numbers are 3 and 6. Most pregnancies, if they're going to occur, will occur in the first 3 tries. All the pregnancies, if they're going to occur, will occur in the first 6 tries. So I don't think there's any risk if somebody's been on it longer, but the likelihood of pregnancy is really low. Basically, it's going to happen in 3 to 6 months, or there's other things going on and we need to move on. Okay? That's a really good question. All right. So if other things aren't working, then we go to in vitro fertilization. In general, in PCOS, we consider IVF a third-line therapy behind lifestyle adjustments and oral agents and gonadotropin therapy. But it can be a first-line therapy if our sperm's not very good, because that's where we deal with sperm problems the best, because we have ICSI, intracytoplasmic sperm injection, where we can inject the sperm into the egg. If the tubes are bad, you bet. IVF is great because it bypasses those. And some people, for a variety of reasons, may want to be more aggressive to begin with, so we can go there. The PCOS patient, if we look overall at the IVF literature, they tend to have a lower pregnancy rate than somebody with unexplained infertility. And that's because oftentimes we can have poor embryo development because of the harsh metabolic environment that PCOS can have. And there are a variety of studies suggesting that the miscarriage rate is higher in PCOS. Now, in a past time, the risk of overstimulating is much higher in the PCOS patient, but now we have protocols and medicines that we can use that we've almost eliminated hyperstimulation syndrome. And then something else that we've addressed, because the hormone levels can be high, because all those follicles get activated, that was one of the reasons why pregnancy rates were lower if you're doing a fresh transfer. So nowadays at Coastal Fertility, nearly all of our transfers are actually using frozen embryos, because we use a complex process called vitrification to freeze them, which works really, really well. And that allows us to address a lining that we've known has been abnormal for 30 years. And so a PCOS patient goes through the stimulation, we get the eggs, get the embryos, and then we freeze them. And then we prepare the lining ideally, and then we put that embryo into an ideal lining. So maybe we're trading a tiny trade-off of freeze and thaw for a big impact on the lining. And that's really helped us. And basically at Coastal, our pregnancy rates for the PCOS patients are the same as anybody else with good ovarian function. All right, but to talk to the problems in PCOS, so here's what the eggs look like. So these are normal, pretty eggs that we get at a retrieval. But notice the PCOS egg. Notice that it's centrally darkened. And actually the shell, the zona pellucida, is more prominent. And that's because they're growing up in a harsher metabolic environment. So you don't expect these to work as well. When we get to day 3, this is what we should see. A beautiful 8-cell embryo with 1 nuclei in each one, no fragmentation. But in the PCOS patient, we are more likely to see slower growing embryos and see all this other stuff. This is called fragmentation. This is cellular debris put out by these cells. It's telling us that they're unhappy and that they're not functioning metabolically well. And these kinds of things are more common in the PCOS patient. But the PCOS patient who especially has significant insulin resistance, if you put them on metformin, the vast majority of them, this stuff will clean up. And that's why many of our patients with PCOS are on metformin, especially when they're doing in vitro fertilization. So things that are really helpful for PCOS patients in IVF include, number 1, a really, really good lab. And we have a superb lab at Coastal Fertility Specialists. And I'm really proud of what Dr. Gray and the team have done. Number 2, we try to use a gentle stimulation. I don't want to get 60 eggs. I want 15 to 25. That's the sweet spot. And if we overshoot, yeah, a lot of those eggs are not necessarily going to be good quality. I mean, with some PCOS patients, they're always going to do their thing and you can't help it. But my goal is a gentle stimulation, try to get right around that 20 mark. Metformin can be very helpful for the PCOS patient to improve the metabolic environment that the eggs would grow on. Then the way we block ovulation is with what we call a GnRH antagonist. And the reason we do that is so that we can use this medicine, leuprolide, to cause the trigger shot, to cause the final maturation of the egg. The trigger shot of leuprolide causes release of LH, which has a short half-life, so the PCOS patient doesn't get hyperstimulation. So this has been a big advent. And then, of course, we're freezing all of them at the appropriate time so that we'll have a beautiful embryo. So all of these things we put into play at Coastal for our PCOS patients, and that's why our PCOS patients are having really good pregnancy rates, just as good as anybody else, because we set them up to win from the very beginning.
2 quick questions.
Yes.
Okay. The first one is, are there birth defects with those medications that we mentioned, Clomid, tamoxifen, and letrozole?
The birth defects rate, we have to talk about when the medicines are taken. If you are pregnant and you didn't do a pregnancy test before you took Clomid or letrozole, the birth defects rate is astronomical. That's why at Coastal, we're always doing a pregnancy test before we give you those medicines. They are what you call teratogenic, okay? Now, for our patients who are taking them properly and we're not pregnant and we use them for ovulation induction, what we see is the birth defects and complications rate is the same as infertile women who conceive on their own, okay? And that, by the way, though, is a little bit increased over the normal population. So, for example, let's take birth defects as an example. I'm a Tennessee graduate. I like simple math. Birth defects rate in most of our women is about 2%. In our infertility patients, it's about 2.5%. So the naysayers will say, oh my goodness, it's increased by 25%. Yeah, it's 2.5%. The risk of small for gestational age is increased by about 25%. It's 4% going to 5%. So that's the magnitude of increases, but it doesn't have to do necessarily with PCOS. It has to do more with the PCOS than the actual drugs themselves. Our biggest risk is actually multiple pregnancy. So the risk of multiples, as you can actually see here with Clomid, and it's actually the same for tamoxifen, is 8 to 10%. It's not increased with metformin. Letrozole is only 4 to 5%. That's my biggest risk, okay? The miscarriage risk, you'll notice, though, is increased in PCOS, and it probably has to do with the metabolic impact on the eggs. So I hope that answered the question.
Okay, let's see. In your experience, do women with PCOS often have twins?
That's going right to where we were leaving off. So let's talk about twins in general. Naturally, to put this into perspective, the risk of twins is 1%. Okay? With a medicine like Clomid or tamoxifen, it's 8 to 10%. Letrozole is a little bit lower than that at 4 to 5%. Now, the 15 to 25% is what's published in the literature at Coastal Fertility. Our twin risk is about 10% with the injectable drugs. And by the way, our twin risk with in vitro fertilization is 3 to 4% because nearly all of our embryo transfers are one embryo transfers because our lab's so good. Okay? So, yep, the drugs increase the risk, but this is the magnitude of that. All right? Other questions? Do we have those right now?
I think that's it.
Okay, so let's finish up because you guys are doing really good. Pregnancy and polycystic ovary syndrome. Pregnancies are more complicated, and it makes sense. If the front end is more complicated, the back end. The miscarriage rate is increased 2 to 3 times. So that's why we're seeing those low 20% range. Blood pressure problems, pregnancy-induced hypertension, preeclampsia, increased 3 to 4-fold, and it can be even higher if we're heavier. Gestational diabetes, so diabetes during pregnancy, increased 3 to 4-fold. Preterm labor and delivery is 2-fold increase. Death rate is increased 3 times. The birth defects we talked about, we think our basic birth defects rate in all of our infertility patients is increased a little tiny bit, but not to a large degree. And then in adulthood, PCOS, yeah, it contributes to weight gain, and so it's difficult. And we know there's all sorts of problems that go with that. But even the thin PCOS patient has an increased risk for cardiovascular disease, including stroke, and we also have an increased risk for diabetes. So it really is a lifelong problem. While we focus here on getting pregnant, it is important to know that this is a lifetime issue. So let's summarize what we've gone through. Polycystic ovary syndrome is a prehistoric disorder with very complex genetic roots. We have to emphasize it is a metabolic disorder with a big impact on the reproductive system. It is heterogeneous, meaning that there's a wide variety of symptoms and lab abnormalities, and not everybody's PCOS is the same. We got 16 different genes involved, and it depends on how they're activated and influenced by our environment. And PCOS can have an impact on nearly all aspects of a woman's life after puberty. The PCOS treatment for fertility starts with lifestyle changes, and they can have a profound impact, but we have to admit it's not easy to do. Simple ovulation induction drugs, pills, can be the next step. Letrozole is our drug of choice. We generally don't want to do more than 3 to 6 cycles. Metformin can be beneficial to a number of patients. If that's not working, we have our injectable drugs and surgery to consider. And then, of course, we have IVF. It can be very, very effective with a good lab, metformin, gentle stimulations, and an appropriate protocol. Frozen embryo transfers are also very key. Of course, IVF and gonadotropin therapy require special expertise. Pregnancies in PCOS patients are more complicated and warrant very close observation from the very beginning. So I'll leave this up here for a moment, but this is just showing. So early in life, we have the excess insulin leading to obesity, and the fat tissue doesn't work correctly. You can get premature puberty, polycystic ovary syndrome, leading to irregular cycles and infertility. And then as we get older, maybe up to 40% of PCOS patients can be diabetic by the time they're 40 years old. blood pressure problems, the impact of weight, all the lipid problems, and what they can cause for cardiovascular disease. Clearly, cancer of the lining of the uterus is increased. It's a question about breast cancer. So we see PCOS affecting women across the spectrum of their life. All right. So that's all I've got this evening. Do we have any more questions?
I don't see any more. There were a lot of good questions there.
Well, I'd like to thank you folks, and we're going to try to turn it around, and hopefully we won't break the camera. And so this is me in all my glory at 63. All right. So thank you for taking the time to listen in. I hope this was useful for you. If you've got any comments, let us know. And if there's other aspects of PCOS you'd like us to talk about at some point, we'd be happy to set up another one of these, maybe talk about the long-term issues and stuff like that. I've got a nice talk that goes into the history of it, which is really a lot of fun, but you better have a couple drinks before we sit and listen to that one. Okay? All right. One other question I'm seeing here. Is there an age limit for these therapies? Well, I guess it really depends, because reproductive aging affects egg number and egg quality. So there can be, but the age limit for a given person could be 30, could be 40. But especially as we get into the mid 40s, these, like the basic treatments, aren't really going to be helpful. Okay. All right. Anything else, anybody? Well, thank you so much for tuning in, taking time from your private time here at dinner time. I hope this has been useful for you. Thank you very much.